Welcome in everyone. I'm having connection problems and I have to have a brief ethical disclaimers as well.
Sure. So thanks for having me. My name is Nick. I am a medical oncologist at Northwell Health. I focus on GI medical oncology. The majority of my practice is colorectal cancer, which is kind of relevant because I think that's what we're talking about tonight. Originally from Los Angeles. I have an MD, PhD. PhD's in computer science because I'm a computer nerd at heart. And yeah, I'm here at Northwell seeing patients, running clinical trials, trying to make colon cancer a little bit. Sure. So I was at like in terms of career, Columbia, then UCLA, which is in Los Angeles, then MD Anderson in Houston. Now I'm at Northwell and really trying to help them raise the bar for colorectal cancer patients. So it's a pretty large health system. It is, let's see, the largest employer in New York State. Now has a number of hospitals in Connecticut as well. So, we're trying to design protocols centrally and use AI tools and other things just to make sure throughout the entire health system, even if it's not in my particular clinic, we're still delivering, a really excellent standard of care, delivering clinical trials, and making sure that patients are getting matched to the right providers and the right studies at the right time.
Wonderful. So, your specialty then, as we're here to discuss tonight, and I'm trying to grab my phone to figure out where Kels is right now, but is colon cancer specifically and biomarkers. And if you'd like to give maybe even just a little introduction as to what biomarkers even means. I think that to our audience, and I'm gonna pause myself for just a minute while I go search for my phone. But if you could, I will hear you. I'm just gonna search for where my Kels is.
Yeah, we're good. I'll just start monologuing. I've got no problems with that. So the disclaimer here is in oncology and in a lot of other fields, we like make up words, and it seems really complicated. So biomarkers, we're really just looking for a signal. We're looking for a protein. We're looking for a patient. Knowing about what biomarkers are relevant, it equips you with the knowledge you need that when you walk into a medical oncologist office, you say, hey, do you think about these things? What's my biomarker? Is this positive? Is it negative? Is that going to impact the treatment decisions? Because the short answer is, if you have a biomarker, it usually means that we get to use some more interesting or better tools to target that specific biomarker, whether it's a protein or a gene or something. So when we're talking about biomarkers, some are more important than others in colorectal cancer. The number one most important biomarker is what's called microsatellite instability. So 85% of patients will have what I consider more run-of-the-mill colon cancer. This is a colon cancer that we treat with chemotherapy, with surgery, maybe radiation. But for 15% of patients, they have a special kind of colon cancer that's called microsatellite high or MSI high. And these are colon cancers that we can potentially cure with immunotherapy. And these are drugs that are very different than chemo. They don't make you lose your hair. They don't make you nauseous. They work by turning your immune system on. So cancer can occur in anyone's body. You probably have 3 to 5 cancer cells pop up on any given day of the week. And your immune system kills them. You probably guess that because no one is forming tumors every day. You only form a tumor when your immune system stops recognizing a cancer cell. So immunotherapy is a way that we can overcome that and allow your immune system to re-recognize cancer cells. But only about 15% of patients with colon cancer will benefit from it. So the relevant biomarker is called microsatellite instability, and we can look at it in a variety of different ways. We can look at protein expression, called immunohistochemistry is a fancy term for that. We can look at it through what's called next generation sequencing, where we can look at molecular genetic markers of this microsatellite instability. The key thing is, if you're seeing an oncologist and talking to them, you say, hey, is my tumor MSI high or microsatellite high? And if they don't know what you're talking about, find a different oncologist, but everyone at this point should. And it's just about making sure that it's been checked. And it doesn't matter if you have stage 2, stage 3, stage 4. Immunotherapy applied for the right patients at the right time might mean we don't even have to do surgery. So I know a number of patients that have been cured with immunotherapy alone, but they have to have the biomarker, they have to know about it, and their oncologist has to know about it too. But that's probably the most important single biomarker. If I'm still monologuing, you can stop me at any point. But
you're doing
there's a
great,
number of other ones
actually.
that we
Like
look at
I
that we
love
think
this. I
about.
just when maybe like yes, the introduction to like biomarkers that can be genetic as well as also very dependent, which also the two interlinked on how the DNA of the cancer or the cancer itself expresses itself, and then how it's going to um, respond to treatment, being very much the clinical thing, the important parts that we that cancer patients should take away from not just colon cancer but also just biomarkers in general.
Yeah. Look, at the end of the day, there's this thing called the central dogma of biology. And look, I'm not a very smart guy. I got to dumb it down for myself. And the way I think about it bases off of the central dogma. The central dogma is DNA turns into RNA, turns into protein. And we can look at any of those three things, DNA, RNA, or protein, and any of them can be a biomarker. So I mentioned probably the most important one for colon cancer, microsatellite high, and we can look at the DNA, the RNA, or the protein to interpret that. And then there's others. So, for example, there's a lot of talk about KRAS right now. So there was recently a drug called daraxonrasib that got presented at a conference recently. It's being tested in pancreas cancer as well as colon cancer, and it targets a specific mutation in a gene called KRAS. KRAS is something that has FDA-approved treatments for specific mutations. So when we're looking at genes, they can mutate in a lot of different ways. Any single amino acid, and amino acids make up proteins, any amino acid can be changed in a protein. So for the FDA-approved currently KRAS inhibitors, which target the KRAS biomarker, you need to have a mutation called G12C. And it's not enough just to see on a report that you have G12C. You need to have G12C, and it needs to be at a relatively high level. And this is actually something I see some people making mistakes about, including some oncologists. Think about it this way. If you have 1,000 cancer cells in a sample and you look at them under a microscope, and all of them have a mutation, if you give a drug that targets that mutation, it's going to work pretty well, right? But if you take 1,000 cancer cells and you look at it under a microscope and only one cell has a mutation, and you give that same drug, well, you're probably only going to kill off one cancer cell, and it's not going to work that well. So for these biomarkers, outside of the MSI high example, but for KRAS G12C, you want to know that it's represented throughout the cancer, not just in a small. KRAS also is implicated in some really important treatments for metastatic colon cancer. We have drugs called EGFR inhibitors. These are called epidermal growth factor inhibitors. We've learned over time that they're only useful for people that do not have mutations in KRAS and NRAS. And I don't expect anyone to, be taking notes and going to your oncologist and having to memorize this like this is a test. It's more that, I'm saying it and maybe you're a little bit more familiar with the lingo. And when you go and you biomarkers, you can say, hey, am I getting a monoclonal antibody in the last year? There's a trial that came out. It's called Alaska. It's not actually spelled like the state. It's a little different. But what Alaska showed is for patients that have a specific molecular profile, and that's mutations in PTEN, PI3 kinase, or AK10, they benefit from taking a simple medication, aspirin, right? It's kind of like a no-brainer, pretty low side effect profile. But the key there is it now allows us for early stage colon cancer patients to do molecular sequencing of their tumor, and it's covered by insurance because it's in our big cookbook guidelines of NCCN. This is great because it gets to uncover lots of other things and information about a tumor. So in my practice and many of the other specialists that I know, we are offering molecular sequencing to all patients with a diagnosis of colon cancer, not just metastatic patients, which is what it was in the past. And it's uncovering really interesting things. There's rarer biomarkers I haven't mentioned, things like gene fusions when two genes are combined. They're really uncommon, maybe 1% of the time, 1.5%, but we're seeing them and we can offer treatment based on that because we're doing the testing. So really, it's just about having that conversation, being equipped with the knowledge that, yeah, these things exist, we know about them. And frankly, if your oncologist is not a subspecialist, and there's very few that are like truly niche. I'm lucky I get to really only see colorectal cancer. It's 85% of my practice. But many people aren't. So being more informed as a patient is awesome because you can come in and you can ask the right questions. And sometimes it's really helpful. I always love patients that ask questions because I get to learn more. You don't know what you don't know. And as much as I try to read and stay up to date, it's always helpful to have that other perspective and that information coming in. Sometimes it's about things that potentially I haven't seen the evidence for. I don't ascribe to as much, or I don't recommend, but that at least allows for conversation about it. And maybe I'll learn something new and change my mind. But that's why I think it's just so important to go in with an open mind and turn any appointment into a conversation, because you don't know what you're going to learn, and your oncologist doesn't know what they're going to learn from you either.
Thank you for that information. We have Kelsey trying
Carissa,
to
do we have our other
jump
guest
in.
on yet?
I am hitting the admit button, and for some reason it is not wanting to let her in. Kels.
Hey, what's up, Kelsey?
Hi.
Oh, there she is. Okay, great.
Welcome. I've been monologuing for 20 minutes, so thanks for coming in and rescuing me.
I'm like sitting there
sorry,
with this wheel
Kels.
of death, and I'm just like, you're fine. It's okay.
I blame Google. It's okay. It's not TikTok. Cool. So I did an intro. I introduced myself. I talked a little bit about biomarkers, colon cancer.
I was in phase 1 clinical trials, and that's pretty much just broad across the board. And also from that standpoint, that they have the support that they need while they are on that, be that they have access to support groups or the financial assistance that they need. So without further ado, I do have one question to immediately start things off, if that's okay with you, Nick.
Yeah, sure.
So someone here says, so my mom had colorectal cancer back when I had just been born. It was discovered basically during this person's labors. My question to you is, at what point do you think I should start getting screened if this might not actually be genetic? So the person's basically concerned if there's any kind of genetic link, at what point do we care about it?
So first off, I'm sorry to hear about your mom. Pregnancy-associated colorectal cancer is real. It's scary. And I will tell you, I have more young patients with pregnancy-associated CRC than would happen just by random chance. So actually, I have a project right now. I'm working with a company to put together a paper on the molecular profile of pregnancy-associated CRC, because I think it's its own disease. I think it's something we need to be treating differently and doing better, because these patients tend to have worse outcomes, and it's really very or 10 years under the age of when your mom was diagnosed, 5 to 10. That's kind of what we quote. So let's say if she was 40, you might be thinking around 30 is when you might want to go and get a colonoscopy. And I found some people ascribe to the gastroenterologist ascribe to these guidelines, some don't. It's just about finding the right person that hears your family history, recognizes the importance of it. And my God, self-advocacy is so important. Yeah.
I wanted to pop in for that one too, because there's certain groups in research that we call protected populations. It's a little more difficult to do research in there because they're considered especially vulnerable populations. And to focus on the main two that are kind of linked but not linked in this one is both pediatric patients and pregnant patients. So a pregnant woman is going to be, we need to treat that population better, right? We need to be extremely fair with them because they are more likely to do whatever it takes, but also while thinking about the well-being of their child, they might not be willing to take steps if they're not properly informed. So it's a very, very specific conversation that has to happen. For a lot of research purposes, a lot of even having a positive HCG would actually exclude a pregnant person from having any kind of relationship to any clinical trial. And that just has to do with the fact that we don't know what these treatments will do in utero. We also don't even know what they will do sometimes to just sperm. So we ask, male patients, hey, don't even donate sperm during this clinical trial. However, as you mentioned, Dr. Ornstein, this is a big one too. Talk to your care provider. It doesn't mean that we don't do any research in this sphere. It's just very, very specific. And you might just have to bring in additional staff into your clinical team. I agree too. Knowledge is power, right? The follow-up to that is, I love this question because I go down this rabbit hole a lot. Is fiber really that important?
Is anything really that important? I mean, look, we have all these trends, and 5 years ago protein wasn't good and fats were in, and now proteins are all the rage. And honestly, I never really believed in that whole fat thing. But there's all kinds of diets out there. There's the keto diet, there's fiber, there's like juicing, there's peptides. Everyone's talking about peptides now. Yep. That's its own ball of wax. So is fiber that important? Maybe. There's some studies to suggest that there's decreased incidence of colon cancer by increasing fiber, decreasing red meat. At the end of the day, live your life, eat what you want to eat. I wouldn't change significantly your dietary habits in relation to colon cancer, except for the caveat that if you have diabetes or overweight, obesity, these kinds of things, you should be focusing on things like diet and exercise, or jumping on the GLP-1 wagon. Like, my God, all of my friends are doing it. I don't understand where this came from. I met up with somebody last week and they had dropped 30 pounds. I was like, wow, good for you. Oh yeah, this injection's amazing. I was just like, I beat my lifetime. But
listen, it happened to me recently too. I met up with a colleague of mine and I was like, wow. And she was like, ah. Yeah. And I was like, listen, if it means that you're healthier, that's all I care about. I do want to add one thing, because I did do one of the papers that I published was on this, where what's most important is the diversity or the biodiversity of your microbiome. So microbiome, fancy words, guys, that just means
poop bacteria.
All of the bacteria that live in your gut. They might be good, they might be bad, and I'll get to the quote. So, like you just mentioned, like keto. I'm not going to sit here and say whether or not it's good or bad per se. I just want the diversity of your meals. I don't think you should ever eliminate an entire food group. There's in the last couple of our culture doesn't really focus that much. My mom's the Mediterranean diet. She's from Spain, but on my diet, she's from Spain, but on my
to drive a superior microbiome besides something I call poop smoothies, which is as gross as it sounds. It's a medical thing, trust me. We give it to people with an infection called C. diff. Yep. No one should be doing that at home.
I had chronic C. diff. So, I don't even want to talk about it.
Balanced diet, health, eat what you want. There you go.
Yeah, I was part of that research too. Listen, it works for the people that need it. I just hope that no one ever needs that research. If you guys want to go down a rabbit hole, by the way, feel free to just type in poop pill into Google and you will have so much resources.
Let's just say they asked me to provide my hours after blender.
Dinner, guys. Let's see. No, stop, guys. Don't get.
That's gross. No one did
Again,
that.
This was part of when I was a little lab rat. This was the first research project I was ever put on, and I was like, who did I upset in a past life?
So here's the thing: it's really effective for patients with refractory C. diff. It's like one. Don't please. No, don't do that. No. So just balanced diet is what I would say. There's all these studies out there that try to purport, hey, Mediterranean diet or eat more of X or Y or Z. And at the end of the day, don't do elimination diets. Don't cut out, all of one food group and become a vegan and only eat things without a shadow. Just eat kind of what you want and try to be reasonable and healthy. Don't just eat hot dogs and cupcakes. That probably wouldn't be good.
And I will say, remember, when we're talking about this particular part, we're talking about almost prophylactically, like what can we do or what is not necessarily concrete evidence to show that you have to do it. But yes, once you're on treatments, and if the only thing you can eat is yogurt 24/7, I just need you to eat the yogurt 24/7 because I need you fed. So do keep that in mind. I had that here as well. Another question here is, let me see how I can word this. Okay, so if a cancer has become metastasized to the GI tract, does that mean I have GI cancer, or was my other cancer more aggressive than was thought of before? I guess is what they're asking.
Okay, good question. Important. Step. We define a cancer based on the cell of origin. So what that means is we care about where a cancer started. And that tells us a lot of information about it. It tells us how it's going to respond to chemo. It tells us how aggressive we should be in terms of surgery or other things. It allows us to stage the cancer because, for example, if a cancer started in the colon, it's in the colon, stage 1. But if a cancer started in the kidney, it goes to the colon, it's stage 4 now. So where it starts is the number one most important thing. And you said there's a cancer that's now in your GI tract. So if this had started in your pancreas and is now in your GI tract, that's considered metastatic pancreatic cancer, not a new cancer of the GI tract. Now, if you had a cancer in the colon and it moved to another spot in the colon, it's a little bit more complicated. We would call that multifocal colon cancer. And that probably isn't going to be metastatic, but depends on where it went. The more common scenario for colon cancer is it goes to a spot called the peritoneum, which is this lining of your abdomen. So all of your internal organs, they're in this kind of bag. That bag is called the peritoneum. And that bag can get cancer on it. When it does, it's a really big problem. It tends to be harder to cure. We still have
where there was one mother tumor that decided that she wanted to live everywhere. Not that you actually have multiple different origin. Like this is a cancer that was born of your kidney, and this is a cancer that was born of this. These are very different. And because of that, we would, if you did have at that point, we're talking about having, we've mentioned this before, tumor board meetings with multiple specialists where we're like, okay, how do we tackle everyone at once? As opposed to, okay, we just have a really aggressive form of, colorectal cancer. We have a fast growing form of, adrenal cancers like to do that too. So when that happens, it is a very kind of fork in the road, and you either do or you don't, and it's not just when you metastasize.
Yeah, you mentioned something. All cases should be discussed at tumor board. So every case we see at Northwell gets presented at tumor board. We talk about it because it doesn't matter if this is, a 1 out of 10,000 very rare neuroendocrine tumor, or if it's a colon cancer that I see, many every day. We still present it because we want to make sure that we have all the experts in the room, and that's not just medical oncology. So tumor boards are a group of people, medical oncologists, surgical oncologists, radiation oncologists, research nursing. The list is like on and on and on. And it's really nice that they're virtual now because it was hard to fit everyone in the room. So it's just important because you get a consensus opinion and you have the confidence that it's not just your oncologist, it's all those other minds thinking about a tumor.
Mm-hmm.
But I completely agree with you, Kelsey. In a lot of descriptions of patients' cancers, they'll say, I've got 20 different kinds of cancer. It's like, no, you have one really shitty cancer and it's spread to 20 places, but it's that one cancer. And we know that's what tumors do, right? So when people think about cancer, a lot of times they're like, this thing growing in me, let's just go cut it out, we're done. The challenge is it can learn to spread, it can learn to go into your bloodstream and go to other places. Say kind of the cat's out of the bag in that case, and it's much more challenging to cure, but we still can't. So even if you have metastatic cancer, depending on the type of cancer, we're getting much better at curing them. So we've gone from, really, it depends on the tumor, but in general, one of the main ways is what we call terminal T cell exhaustion. T cells are the cells in your body that kill things, natural killer cells. And they can get so fed up with all this inflammation and tumor and badness going on that they basically just give up. And it doesn't matter how much we take the brakes off of them, they're done, they're out, they're not coming back to work. That is one of the main mechanisms we see. So we know that some patients will not respond to immunotherapy, but for 70% of patients with metastatic colon cancer that is MSI high, they actually have really, really good outcomes. So Always worth a shot. There are newer treatments that are being developed now that work on different pathways, such like Wnt and some others. TIGIT was one, didn't really pan out. LAG-3 is another that people are exploring, but we're working on it. We're trying to develop this next generation of immunotherapy drugs so we can overcome that resistance when we see it.
Yeah, the one thing I will talk about from the research center, which a friendly reminder that there are things that I can't specifically divulge because I do work directly with these clinical trials, but I will say that this is very much a friendly reminder that there are things that I can't specifically divulge because I do work directly with these clinical trials, but I will say that this is very much, that is part immunotherapy, part chemo. So don't ever lose hope thinking that, oh my gosh, everyone talks about, nivolumab or all of these, Opdivo, Keytruda, and they don't work on me and there's nothing left. There's always something else.
Yeah, EV-Pembro is a great example. One trial, one generation, doubled survival, like overnight. Trial came out, people lived twice as long as they did before that trial. So, we're learning what drugs to synergize, use together. We're learning what is up and coming. And, Kelsey, as you said, there's a lot of things I, would love to talk about, but might not be able to.
Yeah, and I know this is totally
there's one
off
follow-up that just came
topic,
directly to me, which is saying, do you, in any of the trials that you currently work, do you see the hope? There's actually one that I'm really excited about. Especially because
sorry, I was just going to say totally off topic to this subject, but Kelsey is aware.
I think your connection is kind of bunk right now.
Sorry, one of my best friends just started EV-Pembro this last
I will
week.
say that one of them is particularly promising in the fact that, of course, when you get the green light from the FDA to go from phase 2 to 3.
There you go.
Yeah, it's a combo. I was actually on the original EV-302 project, so getting that breakthrough approval letter is everything that you ever want to get, because it's the manifestation of not just all the hard work, but finally seeing the numbers that people want to know, right? Because for you as a patient, you're getting what for you is a death sentence until someone comes in and says it's not over. We have X, Y, Z, and A, B, C, D. So I will say there's one that just got approved for phase 3, which is fantastic. So there's always something in the pipeline. I've always said it's a question of, is it at Emory University or is it at Duke? It just depends.
Yeah, there's people who say, oh, we haven't made progress in cancer. And I point them to a few different diseases. One is a disease called APML. APML is acute promyelocytic leukemia. This was a disease that had a mortality rate of 98%. And I think that last 2% was misdiagnosed people. And in the last, few decades, we have gone from almost certain death to almost certain cure. We cure almost 100% of patients with this disease. So we are learning, we are developing new tools, new techniques, new science. And my hope is that, I mentioned that 15% of patients with colon cancer MSI high and benefit from immunotherapy. I hope that that number goes to 100% because we learn how to use the immune system. We learn how to unlock it, not just for those patients with that biomarker that I mentioned, but all patients. So there's definitely hope. And there has to be, because otherwise I couldn't be an oncologist. This would be maybe a little depressing, but it's about seeing the future, seeing what's coming, and doing that research to drive things forward that keeps me going.
Yeah. This is an interesting one, and this is actually a lot of the work that I do, but how much of a gap still exists between outcomes in clinical trials and the real world oncology setting? So I will say gap in sense of the gaps in general, I will say, are specific to countries as of right now. And that has to do with the financial burden that's associated with any kind of oncology. So if we're talking specifically about the United States, and I'm saying this because I know the person that sent this is not in the United States. So when you are here, this is where a lot of my work as a trial educator comes into play. And I need to make sure that those resources are there so that the reason that a patient is not enrolling in clinical trial is not a financial barrier. We can fix the money part, right? If it's a traveling distance issue, things like that, the United States is huge. So that is something that it has been getting worked on. I know of an initiative at Emory University right now where they actually have a completely outfitted RV that goes into rural areas to do prostate screenings and to do mammograms. That is the kind of stuff that, because of the research numbers, we're able to go in and, again, bridge that gap where, okay, yeah, we have the research and this treatment works, but how do I get the treatment to the person? So that, I will say, is getting bridged, I will say, a lot better. In terms of other countries, I can say that the clinical trial I'm working on right now exploded in France. It's a urothelial trial, so it's for those bladder cancers, and it makes sense. This is a population that does smoke a lot. It's a social activity to smoke there. So I'm not surprised that they had that patient population, and it was nice for them to have an option from the other side. They have social medicine. They don't have to necessarily worry about where the bill is going to go because their taxes cover that, but that's also limited to only things that are approved. So outside of the context of a clinical trial, these treatments are not accessible to people in Spain, France, England at all. So we're working on it. We're working on it. It's not as big and abrupt as I think it used to be, where if you didn't live even in a city center, you couldn't get access to this. That is definitely getting, the gap is getting smaller, I will say.
So it's a good question. We have data in clinical trials. We have these numbers, we have these survival numbers and all these things. I tell patients half people do better, half people do worse. That's not the full story, though. The fuller story is that patients that are enrolled on clinical trials tend to be model patients. They tend to be very healthy. They tend to check all of the boxes, all organ systems go.
Yeah.
It is very hard to get on a trial because they don't really want representative patients of this is what the US population or European or wherever you are population looks like. They want the fittest possible patients to see the best benefit from the drugs so that the FDA or whatever other agency is there is going to say, yes, other people will benefit from this, approved. So the real world outcomes tend to be a little bit worse than on study. Now, that's a loaded statement. Sometimes they can be better. Sometimes the toxicity is actually way better. Because on a trial, I can't reduce the dose of a chemo. So if I have an 84-year-old lady and I know she probably can't handle the standard dose of whatever drug is on the trial, I can't change it for her. I have to give it to her and see the toxicity. But if it's off trial, I can pull my punch. I can drop the dose in half or a quarter or whatever I think as a provider might be appropriate. So outcomes might be a little bit worse off study. Toxicity might be a little bit better. Kind of a mixed bag.
And I want to actually add that about dose reductions, because that's part of also my job, is to kind of bring that feedback back to the pharmaceutical companies and be like, hey, this is what these PI, these investigators, the doctors, we call them investigators. This is the feedback I'm getting. Hey, they don't want to sign up patients for this because you want to put the patient on the investigational product, so the drug that we're studying, and also give them, let's talk about, I don't know, a platinum therapy. So these really like hardcore, heavy duty drugs, and they don't want to. Because like you're saying, it's like, I already have to find the perfect patient. And now you're telling me I need to like sucker punch them and land them in the ICU. I'm not going to do that. So that's also where these more like almost advocacy driven positions, that's where we're coming in and we're saying like, this is what the patients are saying. If you could do blah, 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 like if you would let us half these doses or give us even levels, just say, hey, if your kidney function looks like this and the patient's in this age group, you can dose them here instead of up here. Giving the providers, these doctors, these nurse practitioners, the PAs, giving them the leeway to still practice medicine within the parameters of the trials. These next generations of clinical trials are trying to accommodate that a little better. But yes, at the end of the day, we do have to fit in a box. So sometimes that's why I've always said it's a blessing to get onto a clinical trial, but it's not the end all be all, because we can do a lot of off-label things where we have data that supports giving this to a patient, so we can do that and have a little bit more leeway.
Yeah, I do that all the time. So, but at the end of the day, if you qualify for a trial, it means a lot of people have sat around and said, hey, you, the patient, you might have benefit, or there's at least equipoise. Is very reasonable. And the only way we're going to do better, the only way we find that hope that we're all looking for, is if people enroll on trials, we can discover what works so that we can do better for everybody. So I always encourage people to enroll on a study if they qualify for one.
Yeah, we try. Oh my gosh, this has exploded. Where is everyone? Oh gosh, okay. Okay.
We're here.
You do medical training, you go to medical school, and then you go to residency, and then you do fellowship. Fellowship is where you focus on oncology. And before my first day of fellowship, somebody said, "Hey, what do you want to subspecialize in?" Because the program is at MD Anderson, you have to subspecialize. You can't be a generalist. And I said, "I have no idea. I haven't even started my fellowship. What do you mean I have to pick now?" So I started in a cancer of unknown primary clinic. This is where patients come in with metastatic disease. No one knows where it starts. Kind of Sherlock Holmes it. My mentor was a colorectal cancer specialist. And one thing led to another, and here I am, colorectal cancer specialist. That's my bag. But I really love it. I think it's something that you can really help people, and it is in a really nice place of, it can be really scary and a terrible disease, but you can still cure a lot of patients. And it's also a disease where I think having that little bit of extra expertise can go a really, really long way. I think that's true in a number of different diseases, cancers, but especially with colon cancer, we have all these little tricks that can really help patients. Kelsey mentioned off-label use of drugs. Yeah, we're there. We're doing it because the fun drugs aren't coming to colon cancer right away. They usually go to lung cancer first and then make their way into colon. Yep. But we have learned how to embrace them, and our patients are benefiting. So it's something I'm really grateful to do. And the way I see it, it's a really an honor to be able to help people on what may be the worst day of their lives. So,
yeah. The follow-up one comes to me and says, "Kelsey, why did you not become a doctor?" Life happened. I'm gonna be honest. That wasn't the plan. I actually was like 6 years old. My dad was like, "I'm going to do that." And I was like pointing at Grey's Anatomy on the TV. And he was like, "Whatever you want, my princess, whatever," But no, life happened. My father got very sick with his lung cancer, and I had to make decisions, and I don't regret it at all. I love what I do, especially because, speaking of, just to keep off of the off-label conversation, I was the one that was writing all of the proposals to the companies, like writing directly to Merck and being like, "Hi, this is totally not approved for this particular patient, but let me tell you why we totally would love for you to provide it for this patient." That was me. And I got to put a lot of patients onto medications. I'm thinking of one in particular. Was a Jamaican patient who, we could go down a rabbit hole here. Oh boy. So the Afro-Caribbean population, they have a lot of unique blood properties that usually actually exclude them from clinical trials. Their platelets do different things. Their MCV counts do weird things, and it keeps them off a clinical trial. And everything else looks perfect. So why wouldn't we try it? Like we were mentioning, you're excluding populations, and then we don't get that data to learn about them until it's finally approved. And then we have to essentially find out the hard way. We're kind of going in blind. So this was a whole proposal that I wrote for him, explaining like this is a very specific demographic. We have this way and this way to mitigate this. Let's try it. And this patient had a very aggressive form of renal cancer. So remember, we have two groups. We have that clear cell, and then we have the non-clear cell, which is the really nasty aggressive ones. He had that one. So it was really important to get him on something. And we had reason to believe he would respond to the immunotherapy. And he did. He's actually now, what are we in 2026? He is 7 years out from that initial diagnosis and hasn't actually received any more. He maxed out at his 2 years and is living life. They just welcomed their third child. It's really, I want to call it fun because we're talking about cancer, but it is fun. It's fun to walk into clinic and see someone that didn't think they would even be a father, let alone have 3 children, And I will say, forgive the beeping. Apparently my stove is doing weird things over there because that's one of my detectors. I'll probably have to check that later. We still have time? Cool, we still have time. All right, so the next question is, are there any technologies like AI that you believe are going to actually be transformative in a genuine way?
Short answer is yes. Is AI going to cure cancer tomorrow? No. Is AI already helping us identify patients in their cancer journey to be slotted into the right specialists at the right times? Absolutely. Is AI already helping us identify patients who might benefit from clinical trials and helping us to offer those trials? Yes. Is that going to continue? Absolutely again. So I think AI is a catch-all term that's really fun. I have a PhD in computer science. I have worked on machine learning and algorithms for a long time. AI is kind of another step in that same vein. It's a tool. It's only as good as the problems that you try to solve with it and how you apply it. It can't do everything. It can't snap your fingers and make it do stuff. And trust me, I've tried.
That'd be nice.
But it can do some really magical things. And it can take problems and tasks that might have taken me 3 to 6 months of working 10 hours a day coding and allow me to do them in about 1 to 2 weeks, which is an insane compression of time if you think about it. But if I didn't have that background, if I didn't know oncology, if I didn't have a problem to solve with it, in this case, clinical trial matching and identification, there wouldn't be as much benefit. But I encourage people to try to identify things in your daily life that are annoying, that you might want to solve, or workflows in your work, and just play around with it a little bit, and see what it might offer you. But I do think it's a useful tool. I do think it's here to stay. It's about, in the future, ensuring equitable use of it, because I think that's going to be a significant challenge given the resources that are required to run these tools right now.
Yeah. I'm going to add in from, again, from the research angle, because what else do I do? There was a clinical trial that was basically using AI as, or rather testing to see if we could use AI as a kind of safety net behind our radiologists. So something that happens on clinical trials is we have something called RESIST. I won't get into the abbreviation. It just means that we are actually going to sit there with calipers and measure every single lesion that you have as 3D as possible and give, spit on a percentage. And depending on that percentage, that tells us if you've had a partial response, complete response, stable disease, progressing disease. And it takes 2 radiologists to do that. So you have the original person that has read this report and then someone completely unfamiliar with the case who goes behind them and verifies every single number, every single percentage. This is very specific to research patients. This trial was trying to see if AI could mimic that second radiologist, and the answer was kind of, which was nice because it was only able to be as good as the data that it's already been fed. So if it's never seen this kind of cancer before, it didn't know what the heck it was doing. But in the cases, the one that was focused on here was on breast cancer patients, and we have a boatload of so much data that was able to be fed to the AI specifically in breast cancer, where it actually, oh God, don't quote me on the amounts. I should probably have versed that. But to a certain degree, it made the standard deviation of error so much smaller because it was able to spit back to that second radiologist. Hey, can you check this dot that like both of you missed? If it wasn't anything, we needed the human eyes to look at it. But for a couple of patients, it actually flagged an additional lesion that had been completely missed because it just wasn't big enough for the scan to really brighten it up on the screen. So definitely here to stay. I will say don't watch Terminator because you'll go down a whole rabbit hole. But I do think that AI can be something that can be definitely an additional tool, especially in research, because there's so much extra that we do data-wise that, yeah, we sit there and we crunch a lot of numbers. Our statistician on our team is a gigantic brain, and I'm sure he would like a break every now and again. So
yeah. The other thing I'll point out about AI, 5 years ago, no one was saying AI. Maybe 3 years ago, people started saying it, and it didn't work at all. Like it couldn't do anything. 2 years ago, you're starting to see some inkling of, oh, maybe this can help me with this. A year ago, yeah, now it's answering some questions. Now, in the latest models, it is able to do things semi-independently, autonomous research in things like colon cancer, right? If you go to Claude or ChatGPT, which are 2 models that are out right now, and use their top model, and you say, I'm a patient, give me the top 5 biomarkers in colon cancer, give me 5, and you say, I'm a patient, give me the top 5 biomarkers in colon cancer, give me 5 questions to ask my oncologist to know that I'm being tested for those biomarkers.
The edge of my seat, I'm like, what device has even been created, let alone, sometimes you can just be up at midnight and something keeps you up and you spit it into a machine that spits it back at you with a new idea. It's kind of crazy. Well, I had an attending that's a mad scientist. He was that person that he's like, he will play with his AI. He will like, what about this?
No, I asked Nick's question
you said
a
something,
week ago
Carissa?
to ChatGTP for my best friends. They're getting ready. As they said, they just started EV and Pembro. And I was like, I need you to ask about biomarkers. and I need you to ask these questions. She's like, what tests do I take? And I'm like, okay, bladder cancer, biomarker tests. Tell me the answers. I'm like, just ask your oncologist.
True.
Like,
True. You can, and you can also, I like to say that AI has lessened the informational burden, because I used to give my personal cell to my patients because I know what it does. No, and I will do it again.
I give my email, to be fair, but I learned really quickly not to give my cell out.
I did my cell. Even my attendant would give my cell out, and I'm like, I didn't know they had it, But anyways, but I would do it because when it's 2 a.m. and you're stuck with a question and you don't want to go down the Google rabbit hole that's going to tell you that you died 3 weeks ago, who can you ask? And the answer was usually me. And it's come to a point where sometimes my patient will go to AI first and say, like, okay, my toenail is growing sideways. Am I dying? And at least AI will take the burnout off of you. It'll be just like, hey, it's not a sign of you're okay. This can wait for the morning. So it at least takes that like urge off of. But you can definitely go down the rabbit hole. I'll go on to AI and ask like pain management question, and I will.
Quick follow up to that, and also goes back to the tumor board question, because nurse navigators and tumor boards are two of my passion subjects before I got cancer and now as a cancer survivor. So actually, a nurse navigator is the perfect question also that you can go ask those questions to. And we will be doing an entire session in the beginning of July talking about what the importance is of having a nurse navigator along on your journey, and having a tumor board that sits there and does, and what a tumor board does and what a nurse navigator does. So I think these are two really important topics that a lot of people who are not in, do not have the professional experience that we have no idea. I say nurse navigator or tumor board, and like, these are when I was diagnosed with cancer, these are the first questions out of my mouth, and most people don't even know what I'm talking about.
Mm-hmm.
Yeah.
So anyway, I will let you guys take it from there. We are wrapping up. Kels, do you have any more questions coming in?
That's fair. It is. So I do. It looks like my goddaughter, Dr. Ornstein. It looks like she's been trying to log in and she can't. Her grandmother has just relapsed into her breast diagnosis. So I feel like she asks the cutest questions. So her question right now is, for the both of you, what discovery in this field has surprised you the most that happened recently? Mine wasn't really recent. We have a GI team at Emory when I was still on the patient side of things. So the GI team kind of takes over, but there was the kind of discovery, or I guess a new distinction. And you kind of touched on it actually, doctor. It was the peritoneum. So that like webbing outside layer of your intestines got recategorized as its own organ because it has its own behaviors and its own hormones and its own system. And that made me go down a rabbit hole. And I found out that once you've had a baby, shout out to your wife again, but when you've had a baby, it actually takes about 6 years of the wiggles for your organs to kind of shimmy back into their original place. I had no idea. So yeah, mind blowing. So these are the things that, again, when I geek out, I think about. So I would say that, like, to, be in, I think it was like in 2022 or 23, to be at this point where we're so advanced in science and be like, hey, we have a new organ that we've technically not been talking about or treating that way this whole time, it was insane to me. It was the talk of the workroom. I know that sounds really geeky, but we like all nerded out because it was like, it opened all kinds of doors, right? If we're talking about a whole other ecosystem, so to speak, inside your intestines, you're now having to partition those. You can treat them separately, and you don't have to treat them as one unit where things can get really murky really fast. So that was mine.
So there's a paper that came out this week, and the old philosophy of cancers and how they spread, metastasize, go to different organs was you have the mama tumor, as Kelsey, you described it, and it sheds off cancer cells and they go elsewhere, and that's how it goes. And it turns out that's nonsense, because what actually ends up happening is mama tumor sheds off cancer cells, but any other tumor can then shed cancer cells. So metastasis, things that spread to other organs, can then shed again. That was not thought to happen. But that apparently is what happens at least half the time. So it's a random chance of where the next tumor comes from. So this is specifically in lung cancer. It was a great paper that was just published.
I was about to say, I think you're talking about the lung one. I watch, even
Yeah.
though my father passed now, I watch all the lung stuff. And yeah, that was kind of a, what do they call it? The record scratch kind of moment, because it was that, there's a lot of cancers that, let's talk about bladder cancer again. You want to remove, you have a radical cystectomy, you take out that original tumor with the whole organ. And the idea was that that dropped your likelihood of advancing in your staging because you've gotten rid of that ability of it to metastasize. And so when those patients still did metastasize, you're like, oh, I must have gotten there too late, or I missed one microscopic cell somewhere. And now the idea is like, no, those cells have been circulating in your blood, those circulating tumor cells have kind of already been there, and then they planted themselves. And then those are able to continue to propagate. And that word propagate keeps coming up, kind of like with rose bushes. You don't just plant a seed for a rose, you got to cut it from the main one and plant it, and then it can do its own thing. That's more of the way of it. That secondary plant can also have a branch cut and plant it somewhere else and have a new bush come up. So yeah, that was everywhere. Oh, I will say, I forgot about the bowhead whales. Sorry, it's already 8 o'clock, but I will geek out about whales for just 10 seconds. So cryotherapy, the idea of like using cold, polar plunges and things like that. We actually have some scientific backing to that now. Research that came out in a really interesting sequence of papers where bowhead whales have gene editing abilities that are believed to be prolonged throughout their lifetime, as opposed to something that we can only do for a short amount of time because of their exposure to this really, really cold environment, right? We're talking about Arctic waters.
Gene editing,
if you will, splicing. They're looking at CRISPR therapy for this stuff.
So they got little labs in the ocean, and they're.
I'm like, I loved the way that the Science Weekly put it, because I was just like, okay, so internally we're just snipping away at the bad stuff because of the cold. It's kind of opening this door of what can we do? Because there's people, especially the Norwegians, when they go polar fishing, will dive into the water. Okay, so maybe we should do a clinical trial here. Let's see what the incidence rates for their cancers are and which ones aren't being helped by this and stuff like that. So it definitely is a very premature thing, but it was like whales, from the most unusual places, if you can think of, where, again, people much smarter than me come up with these ideas, and you're like, I see the logic. So between the whales
happens from the oddest
and the
places
intestines, that's where we're at. I technically have one more question, but we're also past 8 o'clock. Do you want me to ask this one, doctor? Do you have time? It does. We get inspired. Let's see. So this one is a very
scientific my other daughter to bed, but I'll do this one.
Oh, hello, little minion.
Somewhere.
So this one's specifically to you. So do you feel that there are areas where patient advocates or non-physician scientists can make a meaningful impact that you would use in your clinic?
Yeah, absolutely. All the time. Like, first off, I'm sorry you even have to ask the question, but the answer is like absolutely 100% yes. I think so highly and strongly of patient advocates, because look, at the end of the day, as I said, I don't know everything. I don't even come close to know everything. And patients also don't know everything. And the more people that inform themselves, equip themselves with knowledge, and whether that's going out and talking to people, being a shoulder to cry on, a person that gives information, a person that goes and advocates on Capitol Hill for more research funding or tools that we can use in the fight against cancer. There are so many ways that your voice can be heard and have just a huge, huge benefit. And you don't need an MD, you don't need a nursing degree, you don't need any of these. All you have to do is have time and want to be involved and equip yourself with knowledge, and you can make a huge difference. And even if it's just in one person's life, that matters. That's why any of us wake up in the morning and go and do what we do. So you don't need a fancy degree. You don't need to spend many, many years of the prime of your life in school. I don't have any regrets, but
you can just reach out to me. Honestly,
you can go and do that and advocate. And I think it's extremely
helpful. That's what I do. I am here to help all of you individuals.
Yeah, the one little thing I'm going to add to that is
go ahead, Kels.
Yeah, that's exactly what you do. Yeah. No, the only thing I was going to add to that is my attending, shout out Dr. Beelan, he used to say that his favorite days was where I had so many research patients that I would actually bring my laptop into the clinic. I'm like, there's no point of like ping ponging between my desk and clinic, so I'll just stay here. And he loved it because whenever we had a break between patients, he would just kind of vomit ideas onto me. And I'll be like, sure. And we had a pharmacist in the room and a nurse practitioner, and we would all talk. And then social worker would walk by and we drag them into the conversation. He loved those days. He would always say, oh my God, it was a great day in clinic. And I'm like, we saw 78 patients. I'm so tired. And he's like, no, but it was a great day. Look at all that we accomplished. And it's just from that, just ideas that you can come up with. Sometimes he'd even come up with something and be like, I'm going to bring that up at tumor board. I need to ask Endo about that. Anything like that. I like to think that we're all the little sidekicks at the end of the day, whether it is, I always say my doctors are both my MDs and my PhDs, because they're the ones that, again, nerd out in the lab and they see all the magical numbers and they take it back to us. So I like to think that I'm a useful sidekick when I can be.
My doctors were the
Anyway,
ones
thanks for
that
having me,
said
guys.
we are happy to collaborate with everyone else on your tumor board.
We shall release, Doctor.
Yep.
We shall release you back to your fatherly duties. Thanks for
Take care,
joining
guys.
us.
Thanks for
Thank you
having me.
so much for your
Yeah.
time, Dr.
Bye.
Hornstein and for Kels. And we will see you
Bye,
again
everyone.
next week for a different one. Kels and I will both see our MOGO viewers in the morning. Thank you, everyone, in the morning. Thank you, everyone.